Hi, we have Julia Adler-Milstein with us today from the course PH555X. Julia, thanks so much for joining us.
My pleasure. Happy to be here.
So the students just completed your session on health information technology, or ICTs, and data, and we're really excited to dive into this topic in a bit more depth and answer some of the questions that have come up this week. As you know, we've had a number of students submitting questions online, and then we'll also have some students submit questions in real time as well.
Great.
And I was just wondering if you could start us off by telling us a little bit about yourself, your research, and also just your inspiration for studying health information technology.
Sure. So I'm a faculty member at the University of Michigan, and I'm in both what's called the School of Information and the School of Public Health. And so my interests really do lie at the intersection of both health information technology, but also really understanding the policy approaches that are being used across the world to foster uptake of these tools, and also sort of how they can be used most effectively to address, key failings around the quality of care, the cost of care, and so I've been really interested in thinking about, what role in particular can the government play in ensuring that this investment really pays off in terms of better health system performance.
Definitely. And one of the sort of core lines of questions that's come up this past week has really been around engaging clinicians. And I know that this is a little bit of a jump from engaging the public sector, but in terms of your own work and sort of looking at what can government do, one of the questions that we got earlier from RGG54 is, how do you build will of frontline healthcare providers to align their behavior with that intended by, sort of, this person says manufacturers, but I think it would be also interesting to speak to sort of public systems as well.
Yeah, it's a great question, and I wish that there was more of a science behind it. But I think at this point, it's in some ways still an art form. I think that one of the keys is understanding why we're asking frontline physicians to go through a very disruptive and difficult change, and helping them see the bigger picture, right? That these tools, we're not asking them to adopt technology just because for technology's sake, right? We've had long-standing challenges with affordability and the quality of care, and and electronic health records and other types of ICTs are one of the necessary components that we think will help move us towards better care. So I think it's really important to make sure that the framing around it is right, and also sort of not to oversell these systems, right? The technology in and of itself is not going to be enough to really improve, and so it needs to be in combination with other things. And so I think what you need is to get your frontline clinicians built into the process of performance improvement and helping them see how IT is one tool that can get them there. And I think their involvement, is key, and having them involved in decisions around which systems to purchase, how to redesign workflows, what the performance metric should be. I think, in general, we see that when that's done in a bottom-up way, with a lot of clinician engagement, then the buy-in is there. And even when things get tough, again, and frustrating, if they understand why they're doing it, that we're on a much longer-term journey to improving health system performance, it makes it easier to weather those rough times.
Definitely. And sort of to speak to that point a little bit more, I was wondering, do you have examples of sort of mechanisms by which, or sort of care centers that have used feedback methodologies that are more acceptable to physicians? And this is informed by a question from Sally JW.
Yeah, so you mean feedback mechanisms specifically around performance, or you could imagine there's lots of different kinds of feedback. So one could be feedback around, like, where is the system working or not working? Users saying, like, I don't like it, when I click this button, it doesn't do this? Or do you mean sort of, I guess, broader feedback around, like, how well is this individual physician using the EHR?
I think probably the first, although both are quite relevant, and I wonder how sort of you pair both engagement in sort of initial uptake with kind of ongoing adaptation of those electronic tools. And one of the discussions that has been trending this week has really been about usability of tools and sort of thinking, how do you engage clinicians or whichever staffs may be using electronic health records or ICTs more generally, and how do you feed back the user experience into the actual design and implementation of the tool moving forward?
Yeah. I mean, I think part of the challenge is just that there's not been a lot of transparency around this. So almost every healthcare delivery organization has some kind of process for user feedback, but then users don't know what happens once they submit that feedback and have no sense about what's done with it, how is it prioritized. And so I think a lot of the, what's acceptable to physicians is they want to know that their voice is being heard, not even necessarily that every time they submit something, there's a change made right away, but that at least someone is listening to them and there's some sort of thoughtful process that exists to triage feedback. And I think, organizations and administrators also need to help frontline physicians understand the constraints they operate under. I mean, they would love these technologies to be more flexible and to be able to redesign user interfaces and make them more user-friendly. I mean, I don't think anyone believes that these systems are, fabulous or easy to use. And so I think part of it is just helping educate frontline staff again about what can be done, where can changes be made, when they're not being made, why, so that there can be more of a dialogue and partnership rather than sort of this, us versus them, or, we hate the system but we have to use it dynamic. But it's hard. I mean, it's really hard, and I do think we're just in an early state of development around the systems, and everyone wants them, and I think believes that they'll get better over time. Again, if you look at principles of usability, we are not doing a good job of designing really usable systems. But I do think that will get better over time. But we need a good process and a transparent process for how that happens.
Definitely. And just to sort of speak to an earlier point that you made and also made with Ashish in the course videos about sort of the promise of health information technologies and yet sort of the struggle in realizing that promise. We have a question from Dr. Jos Vinder, and he sort of is coming from India and sort of speaking to the difficulty of use of ICTs. And I know that we face many similar challenges in the States, and I was wondering if you could speak briefly to sort of that discrepancy between adoption of health information technologies and then sort of meaningful use of those technologies and how that relates to physician perceptions.
Yeah, no, it's a great question. In some ways, it's the question. It's the big question because we're not seeing really compelling evidence that, after these systems are adopted, that a lot of the outcomes that we care about are really moving in a significant way. And I think, the way that I think about this is that, again, we really are in an early stage of this where a lot of the effort has just been focused on getting data into these systems. How do we get, sort of routine pieces of clinical information to get documented in electronic formats? Right? That's again just the tip of the iceberg. Now we have the power to say, okay, now that we have this data stored electronically, what can we do with it? How can we, measure performance? How can we, sort of understand, where there are opportunities to improve performance? There's a lot more that we can do with it, but that also requires reorganizing, and sort of, redesigning processes, redesigning organizational structure. There's sort of a whole set of complementary changes that need to be put into place that are going to allow the technology to really, to sort of have its full potential impact. And again, we're just starting this process, and so those organizational restructuring, that's going to take more time. And so it's not a very satisfying answer to sort of say that, we just need to wait and keep working on it. But I do think that that's the case. We should not sort of give up on the technology. We just have to recognize that it's only, again, a piece of what needs to change. And the reason that I'm optimistic is because the evidence from other industries that went through sort of computerization several decades before healthcare is that it did take almost a decade to see the real payoff from that computerization. And over that decade, organizations, as I said, were sort of going through this restructuring process, asking themselves, how can we work differently now that we have IT? And as I said, I think in healthcare, we're just starting to ask those questions. How can we work differently now that we have electronic health records? And then we're going to have to put in place an additional set of changes. And that's where we'll really see the value.
Great. And just to sort of dive into the information exchange component of that a little bit more, we have another question from Carolina Santos. And in this question, she really sort of asks, what objective, reliable metrics are being used to quantify the meaningful use of EHRs? And I assume that she's speaking about high tech, which you discussed with Ashish briefly in the course, but I was wondering if you could give us a little bit about where the states are at with this. If you are trying to incentivize meaningful use and things like health information exchange, how do you do so in a quantifiable way?
Great question. I think, the reality is that, the measures are not really there yet. So what we have objective and I think pretty reliable measures of are sort of how are physicians using their EHRs. But I think what your question is getting at is, can we then measure the associated impact on care, right? The ultimate outcomes that we care about and the outcomes, frankly, that patients care about. And we don't have, those. I mean, we have obviously quality measures, right? But we don't, I think, have that really strong link between, meaningful use of EHRs and meaningful improvements in outcome measures. Again, as I said, I think that is because we're working towards that. And the way that meaningful use was designed was in stages. And stage 3 meaningful use, which is still upcoming, is really when the demonstrated improvements in care are supposed to happen. And so what you can see is that the pieces have been, put in place to be able to demonstrate that. Stage 1 meaningful use, as I said, was just about getting data into the systems. Stage 2 is really about, I think using that data to improve care, and then stage 3 is going to be about sort of linking the usage of EHRs to improved outcomes. But I think, again, in the context of a very complex healthcare system where IT is only one component, it's a real challenge to sort of say how much can we attribute to the IT versus sort of everything else that's going on and other changes that are happening. And so I don't know that it's that valuable to try to sort of specifically say, oh, it's the EHR that led to this. I think we have to look at it in, as a combination of changes and efforts to improve performance. Again, as which, EHR is going to be one component, but not the only one.
Definitely. And just to pull from the discussion board this past week, one of the key points that came up was, or key questions rather, was, why is this so hard? And that was really centered around HIE and the exchange of information, even from students who are in Canada or in other places in which there might be sort of a more sort of single-payer type model.
Yeah, so it's a great question, and in some ways, picking up on the last question, how will patients know when this is working well? And I mean, I think it will be when they feel like both they themselves and their physicians have sort of full access to all their medical records and medical information, so that they're not information gaps. But as you said, that's often what we refer to as HIE, right? Having that information shared electronically across care delivery settings. It's been hard, in every country that I've interacted with and asked about this, right? No one feels like they've really solved this problem. And I think it's been hard, mostly because it's not just one type of barrier that's holding it back. It's not just a technology problem. It's not just a sort of data privacy and security problem. It's not just concerns about sharing information with competitors or sharing information when you're not sure how that information is going to be used. In the survey research that Ashish and I have done, when we ask about what are the barriers to HIE, what's striking is that everyone reports that all of the barriers are substantial. And so I think that is really emblematic of why it's been hard, is because we're not just trying to go after one type of barrier. There's just a real range of barriers, all of which have to be tackled to make HIE work smoothly. And it's really hard to do, and I don't think anyone has sort of figured it out yet. And even basic things like having a single patient identifier number is something that we don't have here in the United States, and that's made it really hard to know which information should link up together. But then there are other countries that do have those identifiers and still are having challenges. So again, I think it's emblematic of why it's not just one thing. It's really a range of barriers that are all coming together.
Definitely. And the sort of idea of a unique patient ID or access code has certainly come up this past week, and we had a specific question about that from Bang Rebelito from the Philippines, who's sort of really wondering, is the provision of this sort of unique ID and access code enough to safeguard a patient's health records, and then also to sort of deal with some of these exchange issues? And I know that you addressed this in the core session, and you sort of spoke to the multitude of issues just now, but I think this sort of has consistently come up as, oh, wouldn't this be a great fail-proof issue? And I know that you've also spoken about experience sort of engaging patients in their own records and sort of like being the single point of access to the histories of their care, and I was wondering if you could speak a little bit more about that and some of the issues that we run into when we try to utilize a model built on that.
Sure. So two great questions. So I think that the funny thing about the patient identifier is that in some ways it makes things safer, and in some ways it makes it less safe, right? So on the one hand, right, it decreases the likelihood that given information will get attributed to the wrong patient, and that's a real risk. But when you use a single identifier, then it also makes it much easier to pull together all information about a given patient. And then that gets into sort of the data, privacy and security threats. And that's, I think, one of the reasons that we haven't had real momentum behind a single identifier in the U.S. is because people are worried that it'll make it harder to safeguard records. So it's a really tricky issue, and I think there are reasons why they're beneficial and reasons why having them could be harmful, and so different countries have taken different approaches, and as a result. So that was sort of the first piece of are unique patient IDs enough to safeguard? I think in some ways yes, and in some ways no. Your second question around patient-mediated health information. Sort of should the patient be the single point of access? And again, there are countries that are trying that model. And so, in Germany, they're trying to give patients, cards that allow them to store all their information on it. Here in the U.S. with this Blue Button initiative, we're trying to make it easier for patients to sort of download their health information and manage it. And so, it's a good thing, and I think we should continue to work to give patients that access. But I also think that we shouldn't assume that all patients are going to want to be the stewards of their medical information. And I think we have to also, have options for provider-to-provider health information sharing. And so, if a doctor needs to look up something about my record, right, I don't want it to have to depend on me doing something for him or her to have that access. So I think the ideal would be, giving patients that option if they want to, but not requiring and not sort of putting the onus on patients to manage their medical information. And mostly when you look around the world, that is what's happening, where we're giving patients better access to their information, but they don't have to proactively do anything if they don't want, and we're still going to work towards ways that their providers can share information among each other.
Great. And to that point a little bit, or just rather to dive into one piece of that, would you mind just speaking, giving a little bit more detail on the Blue Button initiative in the States and sort of what it attempts to do?
Yeah, it's a great question. So, it came out of the Veterans Administration here in the U.S., which is the care that we provide to the healthcare delivery system to provide care to our veterans. And what it was a button that would allow veterans to basically download all the information from their system. The Veterans Administration has essentially a single electronic health record, which makes it much easier to have a blue button that pulls together all your information. When you start to think about how does the concept of blue buttons scale, to a much more fragmented delivery system outside the VA. The challenge there is that there's not a single blue button that I can press and get all my information together. But what the idea that we're trying to promote is that even if I were to get care from 2 or 3 different places, if each of them have a blue button, I can then pull that data together into a single, source that I might manage, and that way it helps, decrease some of the information fragmentation. So it's really, in some ways, more than it's a concept. When people say blue button, it's the idea that whichever healthcare organization you're getting care from, they should make available to you a way to get your information from there. And so if someone's going to make a blue button available, it's basically saying I'm going to give my patients the ability to, to download or at least view their, their information that we store about them.
Definitely. And I to move a little bit more into the standards and accreditation side of things, it seems like there are a lot of things that are difficult with ICTs, and a lot of things that would benefit from policy level solutions. And I know that this is really, your work has focused on much of this in the States, and I know that you and Ashish are beginning to do some work with the OECD about benchmarking electronic health record uptake internationally. And I was wondering if you could speak to that, and then maybe we could talk briefly about standards and accreditation, where you think that is at, and some of the struggles that might be faced on the international level.
Yeah, so I mean, I saw that a lot of the terrific questions, from students were all about, which country is ahead, in this or that domain, and the reality is, we just don't have good data to answer that question. There's a lot of anecdotes. There's a lot of, measurement that's not, apples to apples comparable. And so it's really hard right now to point to countries and say, this country is really far ahead in this domain, or, this other country is really far ahead in another domain, because we just don't have that comparable data. And so this effort that's been, led with a lot of support from the OECD has said, let's develop a standard tool that could collect data on adoption of various types of health ICTs, and then make that available to countries such that they can sort of collect data and report it in a somewhat comparable way. And so that's going to, I think, for the first time, start to give us some information so that we can answer these great questions about which countries are further ahead than others, and which countries, it's really sort of around cross-country learning, right? Which countries can we look to learn? And I think that what I'm very excited about is that it's not just OECD countries that are participating. There are also low and middle income countries that are participating and interested and want to collect data in this comparable way. So I think over the next few years we'll start to have some of that information so that we can answer those questions. And right now, as I said, it would largely be sort of anecdotes, and it's not grounded in sort of real data. And so anyway, so those questions are, I think, I love them and I want to be able to answer them, but I want to tell you, be able to respond in ways that are meaningful, that mean something, and we just don't know yet what those are.
Definitely. And do you think that our countries sort of looking across borders and sort of exploring what is going on, even if they don't have necessarily kind of a hard and dry baseline or sort of way to measure what countries are doing in a comparative way? I know that sort of maybe in more qualitative ways and more sort of descriptive accounts. Have you seen examples of countries using experiences internationally to inform their own strategies?
Yeah, so I mean, certainly, in the forums I'm in conferences, and I mean, you definitely see a lot of interest in it. I don't know that I can point to a specific example of a policy where I can say, well, that country, clearly took that policy from this other country. But no, absolutely. I think that, that sort of at that most senior sort of government policy level, absolutely countries are looking at and learning from, other countries' experience, things that went well, things that didn't go well. So I think there is definitely that level of interest and recognition. And as I said, I think just the level of interest in this OECD effort from a wide range of countries is indicative of sort of the fact that people have their radars out to look for, where there are opportunities to learn from other countries.
Definitely, and while very difficult without sort of a strong benchmarking strategy, some of the questions that have come up are around standards and accreditation. And Maddie PT says or asks, how close do you think we are to having global industry standards for interconnectivity and functionality of EHRs? Do you think this will be driven by regulation, WHO or other cross-country levels, clinicians, or software developers? But really just sort of where do you see this standardization and accreditation going?
Yeah, so there's a lot of debate and discussion around around this, and I think that so I think the first thing to be clear on when we talk about interoperability too is like, what kinds of standards are we talking about? Are we talking about standards for how to transport information, or are we talking about standards for how to understand information, right? Sort of content and vocabulary standards. Those are two very different types of standards. I certainly think that that we were going to make more progress around this sort of transport standards, and even some progress around sort of structured, for example, summaries of care that can have sort of key types of information within them. I think we're starting to see a lot of that in the U.S. already around CCDs. And that's sort of a structured document summary format that can be exchanged across different types of platforms. And I think that you could imagine that could start to scale internationally, though again it's hard. I don't think that there is an overarching body that's likely to mandate those standards, just because that doesn't exist in an international forum. But I think certainly country by country you could imagine greater uptake of that. I think for the vocabulary standards, that's where there's going to be more challenges, and we've really struggled here in the U.S. I think to get to that level of detail, because it's just so painstaking, because there are so many pieces of health information that are captured in different ways, and so it's much harder for me to see how we get to that, across countries, let alone within countries. So I think what will be interesting to see is, particularly as some of the EHR vendors start to move internationally, whether that they'll sort of take the interoperability with them, such that if you are, an Epic user in, in France, will you be able to communicate with Epic users in the United States? So we may get some interoperability and health information sharing, that happens as a result of, within vendor systems, but that's not really what we're aiming for. We'd really like it to be across platforms, but I still think it's going to end up being mostly on a country-by-country basis.
Interesting. And just to sort of shift a little bit, but thinking about low and middle income countries and countries that have less sort of built infrastructure in this space, but do have the potential to really leverage sort of mHealth technologies, mHealth strategies for healthcare quality. And how do you think that these strategies can be utilized to address issues of health information exchange? Obviously, you're diversifying sort of the types of platforms that people are using, but in many ways could potentially be standardized as well at the country level, as you suggest?
Yeah, I think mobile health, in particular, cloud-based solutions. Here in the U.S. we have, some EHR vendors that are primarily cloud-based, and others that are, rely much more on local installations. And so I think, my guess would be that in many of these other countries that, cloud technology will be, much more appealing and flexible. And then will be ideally much more tied into, mobile platforms, and mobile, computing. And I think in some ways it's exciting. It will be really exciting to watch low and middle income countries that don't have, as you said, as much of an installed base that they have to work with, and legacy systems that they have to migrate from. Because I think it'll give them a lot more flexibility and ability to use sort of, the latest and greatest technologies that are out there today. And so I'm very, very, as I said, excited, and I think certainly keeping my eyes out to see, what they're gonna do. And it'll be particularly interesting to see, as governments, in those countries feel like they're interested in pursuing them, how do you build a policy approach around that? Because at least here in the U.S., we did not specify, the technical model that had to underlie the EHR system. But you could imagine, in some of these other countries, the governments could, think much more specifically about how to get more flexible technologies in place. And as I said, I think it'll be really exciting to see.
Definitely. And what do you see the role being of government? One of our students asked, in lower income countries where the majority of population is below the poverty line, and in context where you would imagine there would be a higher use of mHealth technologies, there might also be a corresponding lack of governance or sort of infrastructure to support that in a centralized or coordinated way. And I think much of what we've seen thus far with mHealth has been a lot of excitement and a lot of innovation, but not necessarily that coordination, and certainly not at the public level.
Yeah. Yep. I mean, I think that's right, and I think that it's going to be a challenge, and so I don't, as I said, I don't feel like there's that one country I can point to, as the model. But this is where I think some, at least middle-income countries who do potentially have more capability, on the governance side, it'll be interesting to see, where that develops. And I think, there's just also a lot of attention now on healthcare system delivery infrastructure, as a result of all the Ebola, attention. And so I think that will also create potentially a window of opportunity to say, can we really improve the governance around healthcare delivery systems? And that may then include, some of the IT piece. So to the extent that there is, renewed attention on building, robust healthcare delivery infrastructure, I do think that then IT will end up being a piece of that. So maybe coming out of this, this horrible epidemic, we will see, a silver lining.
And sir, I think directly related to that, although not mentioning the Ebola epidemic specifically, we do have a question from a student, Smuku, about examples of success stories in which mHealth has been used in sort of a response context to be able to respond to maybe more acute issues, something like the Ebola epidemic, or even specifically, as you've sort of heard in your own community talk about the Ebola epidemic. Have you heard of sort of anything that's going on with regard to health information technology or mHealth to address what's happened?
Yeah, it's a great question, and I'm sure there are, and so but I'm trying to think what if there's a good example that comes to mind. Yeah, I mean, I think we've mostly seen stuff around sort of SMS-based, alerts, with cell phones, which I think are, again, helpful, and they're there, and it's a start. But I think, increasingly there will be a lot more, going on, and there probably are good examples that people who are more closely track the mHealth side will know about. And I actually think it would be something good to look up and share with students in the course, because I think it's obviously something that's very relevant and happening now, and it's not something I'm as close to.
Great. And those strategies that you talked about, that sort of case identification, more sort of SMS, we have X amount of patients at this clinic, that type of thing?
Yep. Okay. Yeah, I suspect it is happening, and I just, again, I don't know of the specific example to point to.
Great. And we have a question from a student that's a little totally different than we were just talking about, but asking about sort of non-healthcare institutions and thinking about the role that, as patients are sort of in other institutions such as prisons and other public healthcare organizations, how do you ensure that people who may be seeking care outside of a traditional hospital setting are able to integrate with the healthcare system, and is there a role for ICT with that?
Yeah, so absolutely, and I think I mean that there's been they've not been left out in the sense there are electronic health record products that are specifically targeted to FQHCs and even prisons, and there have been some was it in Oklahoma? Now I'm getting all my examples confused, but where there was actually a pretty good effort to achieve interoperability between the prison electronic health record system and the local hospital. So I actually think that, I mean, part of the challenge is we don't have as robust data to know where adoption stands in those settings. But again, if we're just going to look at anecdotal evidence, there are certainly examples where there is, in some ways, some more innovative stuff going on in those settings because they don't have the same, same sets of challenges. I mean, they have different challenges, I guess. But sometimes because they fall under the radar and they're not as subject to, for example, like the federal meaningful use criteria and things like that, then they have more ability to be innovative. But I think more broadly, the question is making a really important point, which is that we can't think about healthcare providers too narrowly, because the value of these systems will really only be realized when the whole healthcare delivery system is interconnected, and anywhere where you get care, right, that information needs to be captured and able to follow you between care delivery settings. I mean, another example that's often discussed is dentists, right, who have important health information about patients. And so I think we need to think about this much more broadly, and probably hospitals and sort of primary care and and sort of what you traditionally think of as, of ambulatory care providers, it's the right place to start, right? It's a big group, but we can't stop there. And we need to really make sure that we continue to push to get a broader range of healthcare providers and even other people who, don't even directly provide care, but care for patients in other ways, to try to get everyone as part of, the system and part of the solution.
Definitely. And in your work, what have you found as some sort of policy solutions to that issue in terms of sort of making a more comprehensive and community-based approach to health information technology?
Yeah, no, it's a great question. I think, it's hard because in some ways we've put so many resources and so much time and effort to just get, the core folks, involved and on board, that oftentimes it's sort of hard to think about, well, how do we take that next step? And I mean, frankly, in the U.S., we're struggling with this right now with thinking about post-acute care settings, and how do we make sure that nursing homes and sort of, facilities like that don't get left behind. And so, I don't know that I think that I know the right set of policy solutions for it, other than just, I think it will become increasingly obvious, right, that they're where we need to turn next, when patients move between these settings, and if they go from a, fully electronic setting to fully paper-based setting, right, that contrast is just going to be so stark. And so, I hope that will create some of the momentum to make sure that sort of all settings get brought along.
Definitely. And have you seen some policies such as readmissions penalties, or things that might not necessarily be geared specifically towards information technology, but which would have implications for a hospital or a care setting in terms of incentivizing maybe better communication and interoperability with sort of post-acute care, as you mentioned?
Yeah. So I mean, I suspect absolutely that when there are penalties put in place for readmissions, that there's going to be a drive to improve information sharing. I think we're also seeing, again, here in the U.S., experimenting with accountable care organizations and trying to make providers more responsible for the total cost of care for a patient, and so that is also leading to efforts to increase information sharing and information integration. And so, I think, yes, like these are all forces that are going to lead to, to sort of those same pressures around getting, health information exchange, happening between systems. But again, it comes back to the fact that it's very hard to do. And so the little bit of data we have right now around this suggests that people are really trying to make it happen, but that it's been really hard and challenging to accomplish it. So I think it's still going to be a sort of slow and difficult road, even though now there's a clear reason, to do it.
Definitely. And we've spoken about accreditation and about some of those different types of policy mechanisms earlier in the course with Alan Kachalia, as well as some of our other guest speakers. And I guess I was wondering if you could, just take a few minutes to share, I think, with the PH505X community, some of the work that you're engaging in now, and sort of what's up next and what you're excited about.
Sure. There's a lot of fun research to do, today. I mean, really, what I'm most excited about, it picks up a little bit on what I was talking about earlier in this session when I was talking about what we've learned from other industries and how it really took this period of about a decade for organizations to adapt and like take advantage of these new IT capabilities that they had. And so I'm very interested in thinking about, like, what does that process look like for healthcare? I hope it's not going to take a decade, and I hope that we can figure out, like, what changes we need to make to take advantage of this new data and information that are available in EHRs. And so I think, for example, thinking a lot more about performance measurement and monitoring. So can we take this data that we have and build even just something basic like a physician performance dashboard, right, that give physicians, in some ways for the first time, real insight into how they perform compared to their peers, right? Most physicians just don't have any way of knowing that. And so, and it's, there's this adage, right? You can't improve what you can't measure. And so I think even really basic things like starting with with measures derived from EHR data that can be updated essentially in real time will be a really powerful way that organizations can start to shift their the way that they do business around data. And then you could imagine starting to tie incentives to those performance measures for physicians. So all of a sudden now, right, they have the data, they can have an incentive to to improve, and then try working differently to see what they can do to improve those measures. It seems like a really simple, obvious thing, but there's nothing about an electronic health record that would make you do that, right? I mean, you have to see IT as a tool that allows you to capture data and create measures that you can then tie incentives to and create a culture of performance improvement, right? So it's that sort of bundle of things that I'm really interested in studying and thinking about, where is IT making a difference, and what are organizations doing to ensure that happens. And so I think we're going to start discovering, right, all these different ways that these systems are being used, and that's really where the value lies. And so that's the research that I'm really excited to do, and to ultimately convince people that this huge investment and this huge sort of disruption that the industry has gone through in terms of learning to work in new ways was worth it. And I do think it is, but I guess I think it's going to take time, and we need to really understand what needs to happen beyond just adopting the technology to have it make a real difference.
Definitely. And it's very aligned with the session that we just had with Maureen from IHI on quality improvement and sort of the need to really understand how you perform, how that is relevant to sort of your peers' performance. And do you see, I know that in sort of non-healthcare related mobile technologies, or rather sort of just computer-based interfaces, you have a very strong analytics developing. Do you see the potential for things like that in healthcare and used sort of through ICTs?
Huge. There's just no question that is going to be, the big. It already is, and it's just going to continue to grow, right? Because we have all of these electronic health record systems in place capturing a huge amount of data, and we need to make sense of it. And so that's where the analytics piece is going to come in and be tremendously powerful. That being said, I think we have yet to really see that happening. There is so much talk about analytics and big data and this and that, and I would really have trouble pointing to like these huge insights that have come from that. And again, I think, you know, there's this sort of hype that's come with all of this that makes it sound like it's going to be easy, like these insights are just going to emerge and then we're going to know how to treat diseases better, or and it's just not going to be that easy. And so I think there are real issues with the data quality and you know, accuracy, missing data, right? A bunch of challenges, and so we're going to have to work through those. And so I think the insights are there, and I think analytics are going to get us to it. But again, it's not going to be easy. I think it's not, you know, it's not even low-hanging fruit, right? It's going to take some real thoughtful effort to figure out, you know, how to you know, generate knowledge from all this new data. But just the fact that the data is there is a huge step forward, and I think we'll learn how to take advantage of it. And it's the next. I mean, I really do think it's the next frontier, and not just EHR data, but as you said, you know, mobile health data. I mean, you know, personal data that patients store and track about themselves, right? Once we start to put together what's often thought of as, you know, like the electronic health record and clinical data with the phenotypic data, right? Then you can just imagine this really, really rich data set that's going to help us understand, you know, health and disease, I think, you know, in fundamentally new ways.
And before we sort of finish up, do you have any words of advice for our students in sort of as they engage with data in their own clinical settings or as patients, sort of how best to think about this to move that agenda forward and to really sort of be productively engaging with ICTs and doing so, as you suggest, in a way that might also bring into light quality improvement, might sort of be both collecting information but also reflective of that information?
I mean, I would start with even very basic things like, you know, asking for access to the data, asking for measures of performance. If you're a clinician, right, to say, I want to, you know, I'm putting in all this data about my patients. I want to be able to see, you know, metrics about my patients. I want to see metrics about my performance relative to my peers, right? Start pushing to be able to see that data, see the measures, you know, see what we're learning from it. Because again, I think, you know, if the data is just captured electronically, we don't do anything with it, right? We really won't have, you know, we're not going to see the value. But like, let's unlock the data, let's free the data, and let's get it, you know, into in some ways as many hands as possible, so that we can start, you know, learning from it. And I think to the extent that people start to demand that, you know, that data, it will start to create the momentum behind that. And so I'm really, I really think that, you know, that a lot of times, you know, it's just about having, you know, the interest in asking, and that can lead to, you know, a meaningful response.
Great. Julia, thank you so much for joining us today. I think it was wonderful to dive into a little bit more about information exchange, the role of governments, and of course the many challenges ahead, but also some of the sort of promising things on the horizon with regard to ICTs.
It was my pleasure. It's fun to do. It's a fun set of questions, and as I said, I think we're in the beginning of a long but exciting journey.
Great. Thanks so much, Julia.
Great. Take care.